So, since we're just discussing about the urological part of the general surgery, so particularly it's a continuation of the previous lectures, and today we'll be talking particularly about the epididymal diseases. So, for that, you should know that epididymis is kind of a transport tube because because you know that this is, if you could look at this picture, you can see the part of the testes, and just above the testes, these are the seminiferous tubules within the testes, and they're connected to this epididymis. And you can see here, like, this is the head of the epididymis, and this is the body of the epididymis, and this is the tail of the epididymis, which is further connected to the vas deferens. So basically, the most important function of the epididymis is like the transportation of the sperms, because we know that the sperm production or the spermatozoa production is basically the job of the testes. And whenever the spermatozoa, they're formed in the seminiferous tubules of the testes, they're transported to the epididymis, and through the channels of the epididymis that goes to the vas deferens, and that's how the process of the spermiogenesis is continued. So particularly talking about the different kinds of the pathological factors in the epididymis, there can be like the epididymal cyst, there can be epididymal tumors as well, and there can be some inflammatory condition like the epididymal-orchitis or epididymitis. So we'll be discussing these one by one. If you could see and appreciate in this diagram that this is the normal anatomy, and you can see that this is the scrotum and the normal groin. If we talk about the anatomy of the normal groin, we know that the testes, they are enclosed in the scrotum, and these seminiferous ducts are actually linked to the epididymal ducts, and they are then emptying into the vas deferens, which is also located in the spermatic cord. So what happens, like, this is the testicles, and just at the head, at the upper pole of the testes, you can see the epididymal head, the body, and this is the tail of the epididymis. So these epididymal cysts, they are most common on the head of the epididymis, particularly comprising the upper pole of the testes. And they can be unilateral, but most of the time these epididymal cysts, they are bilateral, they are multiloculated. There can be multiple cysts in epididymis, but they can be single large cyst which actually which is actually present behind the testes. So these epididymal cysts, they are a common finding, and they're most common in the middle-aged men. They're multiloculated, and they can be bilateral as well. So most of the time they're composed of the clear fluid. Sometimes when you try to aspirate these cysts, there's not too much like the fluid that can be aspirated, because they're most of the time multiloculated, and because of the loculations, the fluid actually gains kind of the hard consistency, and because of that it's difficult to aspirate. So what you do in case of the epididymal cyst, when the patient is non-symptomatic, and sometimes because these epididymal cysts, they can enlarge in size, and also they can cause a persistent dull testicular pain. So because of that, if there is a persistent chronic testicular pain, you have to excise these cysts, and simple excision is the treatment of the choice in case of the epididymal cyst. So keep this thing in your mind, that they are usually just like the simple ovarian cyst, and if they're clear in fluid, and if they are non-symptomatic, you can leave them as it is. No surgical intervention is required. But sometimes when they are larger and they are actually compromising the testicular function, then they need to be excised. So most of the time they're simple cysts, but they can be complex cysts as well, causing the testicular atrophy and the persistent pain. So in that case, excision is the treatment of the choice. So, how you're going to diagnose the epididymal cyst, and sometimes starting from the symptoms and signs of the particular disease, a patient obviously will come to you with the testicular or the scrotal swelling, and it can be, you can think of number of other differentials, like the you can think about the varicocele, you can think about hydrocele, you can think about epididymal-orchitis, but most of the time these cysts are not painful, and if you touch the testicular or the scrotal swelling, that would not be tender. So in order to differentiate it from the hydrocele or varicocele or the inguinal hernia, the choice of the investigation is the ultrasonography. So you can see here in this diagram that most of the time this is the part of this is the testes, and you can see that this is a small cyst which is located on the upper pole of the epididymis. So ultrasound is the main investigation in case for the diagnosis of the epididymal cyst. There's another important thing which is called as a spermatocele, and if we particularly talk about the spermatocele, obviously sperm is the reproductive egg, which is like the counterpart of the egg which is produced in the males, and obviously cele means something encysted, like the cyst. So spermatocele is a kind of the cyst which is compromising of the seminal fluid, and obviously it's not only the seminal fluid, but most of the time the seminal fluid along with the sperm. So if you could see in this diagram, you can see here that this is again a similar diagram, and you can see that these are the testicles, and just inside the testicles there are kind of a lot of seminiferous tubules, and they're connected to each other like the bunch. And this is the epididymis, the part above on the upper pole of the testes. This is the epididymal head, and you can see here that this is the body of the epididymis, and going back, this is the tail of the epididymis, which is being connected to the vas deferens. So spermatocele is most of the time involving the head and sometimes the body of the epididymis, and spermatocele usually, because there's a lot of production of the seminal fluid, and sometimes there is a lesser drainage of that fluid, and because of that there's a kind of the cystic collection of the seminal fluid along with the sperms. And in case of the smaller spermatocele, usually the surgical intervention is not required. But in case of the larger spermatocele, again, the choice of the treatment, particularly for the large spermatocele, obviously would be excision. But sometimes when the spermatocele, or even if the epididymal cyst is present and it's causing the testicular atrophy, dull egg persistent pain, and because of the testicular atrophy or the testicular infarction, that can lead to the infertility, and you can always go for the epidydymectomy or orchidectomy, depending upon the complications, depending upon the symptoms of the patient, and the extent of the infarction which is being produced in the testes. So you can see here in this diagram that this is the kind of the junction of the head and the body of the epididymis, and you can see here the spermatocele. So spermatocele, they usually, most of the time, I already have discussed, like the epididymal cyst and the spermatocele, most of the time they involve the upper part of the epididymis, like the head of the epididymis is like the most common part in which you can find out to have the spermatocele. And most of the time, because it's a fluid, it's a seminal fluid, so the percentage of the spermatozoa is significant in case of the spermatocele. So if there are small spermatoceles, obviously there's not too much to do, and there's no surgical intervention, and they can be left untreated or ignored. But in case of the larger spermatocele, the main concern is basically the testicular atrophy or the testicular infarction, because when there would be a larger spermatocele or there would be a larger epididymal cyst, that obviously will compromise the blood supply of the testicles. And whenever we know that the blood supply of the testicles is compromised, there's a kind of the risk to the testicular infarction, and because of that there can be testicular atrophy. So in case of the larger spermatocele, you have to obviously excise them, and if there's a kind of the focus for the infarction or the atrophy, the choice of the investigation or the choice of the investigation for the spermatocele obviously would be ultrasonography, and the choice of the treatment would be excision. But most of the time, if there is testicular atrophy or the infection, then the choice of the treatment obviously would be epidydymectomy or orchidectomy, depending upon the complications and depending upon the signs and symptoms of the patient. So this was a little bit about the epididymal cyst and about the spermatocele. And keep in mind, if the cyst or the spermatocele is smaller in size, you have to leave them as it is. There's not too much to do, and not to worry about them, because they are especially if we talk about the epididymal cysts, so they are very much common in the middle-aged men because of the hormonal influences. So always keep in mind, in case of the larger cyst, the treatment, or we have the treatment options, particularly we have are like you'll go for the excision or the evacuation of the cyst. The smaller cysts, since they are part of the kind of the normal metabolic changes that the body undergoes, so because of that you can just leave them ignored or unattended if the patient is not symptomatic and there's like the no persistent kind of the pain, particularly the testicular pain. So there's another entity which is very much important and very much common, which is the epididymal-orchitis. And obviously this is the first most important thing which will come into your mind when the patient will present to you with the painful inguinal-secretal swelling with the redness and obviously fever. So let me tell you, there's a kind of the typical scenario. A young boy is coming to you and he is saying that he has developed a kind of the testicular pain from the past one day with a high-grade fever. And most of the time you'll think about the inflammatory process. So if you talk about the inguinal-secretal swelling, what comes, like particularly if you talk about the differential diagnosis, so what comes into your mind when a patient is coming to you with inguinal-secretal swelling? The first and the important thing, it is a painful, you think about some kind of the inflammatory process, right? And if then you'll think about the inguinal hernia, particularly the indirect inguinal hernia, which is lateral to the inferior epigastric vessels and coming from the deep to the superficial inguinal ring and coming down to the scrotum. You'll then obviously you think about kind of the hydrocele or the varicocele and testicular torsion as well. So most of the time inguinal hernia, which is not obstructed or which is not strangulated, incarcerated, that present as a painless swelling until and unless it's not obstructed or incarcerated. But the hydrocele and the varicocele, most of the time they're also painless. But if a young boy is coming to you and he is telling you that I've developed a painful swelling, and it's not giving you kind of the history of the trauma, but he's giving you the history of the fever, high-grade fever, then you'll think about some kind of the inflammatory process. But most of the time, if you talk about the painful swelling, or the differential that would come into your mind is a testicular torsion, because the history of the testicular torsion is mostly very, very brief, and the most important and the striking feature of the testicular torsion is the development of the pain. And the pain is usually progressive, and it is kind of the disproportionate pain and severe in intensity. But if we particularly talk about the epididymal-orchitis, it is a kind of the inflammatory process, and obviously because of that it's painful as well. So it's if it's only the inflammation of the epididymis, then this is epididymitis, and if it's involving the testes as well, so then this is the epididymal-orchitis. That's the inflammation is not just limited to the epididymis, but it's also involving the testicles as well. And that's why this is called epididymal-orchitis. So if we particularly talk about the epididymal-orchitis in the younger men, and if we compare it with the older men, the causative factors or the focus of the infection is different in both the age groups. And young men who are usually sexually very active, so most of the time they are because of the sexually transmitted diseases. But if we talk about the older men, most of the time the infection can be because of the enlarged prostate, urinary tract infection, or the obstructive uropathy, because we know that when there is enlarged prostate and it's causing a kind of the obstruction to the flow of the urine, there would be stasis of the urine, and whenever there's a stasis, there's a bacterial proliferation, and obviously the stasis will lead to the development of the infection, right? And that infection by the process of the prostatic, by the channels of the prostatic urethra, that will goes up to the vas deferens, and that's how it's transmitted to the in a retrograde fashion, and it's involving the epididymis and the testicles as well. So most of the time, if we talk about, like I already told you that epididymal cyst and the spermatocele, they're involving most of the time the head of the epididymis, and this epididymal-orchitis, the inflammatory process is mostly involving the tail of the epididymis, right? And in younger men, the causative organism for the epididymal-orchitis is the chlamydia trachomatis, and it can be gonorrhea as well in some cases. But in case of the older men, obviously the causative factor is the ascending infection from the urinary tract infection or the prostatic urethra, and it can be because of the obstructive uropathy, secondarily to the obstructive uropathy. So this is something very important to know, that the organism in the different age groups would be different, right? Because of the focus of the infection is different. Like in the case of the younger, the causative organism is chlamydia trachomatis, which is very much known for the sexually transmitted diseases. And obviously the other causative organism is the gonorrhea group. But in case of the older people, the causative organism would be those involving the urinary tract, like most commonly E. coli. So why this is important to know, because you have to give a targeted therapy against the organism. Like if we're talking about the younger group, the drug of the choice is like the quinolones or the doxycycline, and in case of the older patients, you have to send the urine for CS as well, and whatever would be the organism in that particular culture, you have to give the targeted therapy against that organism. So talking about the pathophysiology, I have already given you a brief description, but mostly this is the chlamydial infection or the gonorrheal infection in the younger age group involving. And obviously the other causative factor in case of the epididymis or the epididymal-orchitis, in case of the older patients or older men, would be urinary tract infection. So most of the time, whatever the cause, whatever the organism, and whatever the focus of the infection is in case of the epididymal-orchitis. The part of the epididymis involved mostly is like it starts in the tail of the epididymis, and then obviously it generally progressively spreads to the remaining part. So keep in mind the age groups, the causative organism, the focus, and most commonly the part of the epididymis which is involved in case of the epididymal-orchitis. So particularly what would be the features in case of the epididymal-orchitis, obviously the patient will complain to you that I've got a swelling, or I've got a pain in my testicular region or the scrotal region, or sometimes he can also tell you about the pain in the groin. And since it's the inflammatory process, so pyrexia would be the important cardinal feature for that. Patient will tell you that I've got a high-grade fever. And obviously the inflammatory process is like it's involving the swelling of the particular part. So patient will present to you with the scrotal inguinal scrotal swelling, and he will narrate you that whenever scrotum is touching any surface, or I touch my scrotum with my hands, it's quite painful. So the tenderness is something very important. So depending upon the physical, depending upon the symptoms of the patient, you're going to go for the general physical examination, and particularly the systemic and the local examination. For the local examination, because you have, first of all, start from the inspection, palpation, percussion, and auscultation, obviously. But the most important steps are inspection and palpation. First of all, inspect the swelling, the size of the swelling, the consistency of the swelling, inspect for the color, and obviously the temperature and the redness. First of all, if we're particularly talking about the inspection, there would be redness, and the second most important thing in the palpation is the temperature, because if it is epididymal-orchitis, then the temperature of the swelling would be higher as compared to the rest of the body. And let me tell you another thing. You'll also go for the cuff impulse. You go for the transillumination to differentiate from the hydrocele and the varicocele, and you'll also examine for the like if you can get above the swelling or not. If you can get above the swelling, then you'll think about the hernia. But if you can get above the swelling, then you'll think about like the hydrocele or the varicocele or the epididymal-orchitis. And what you do is, another important test is like when you lift the testes, you have also to differentiate from the torsion of the testes, right? But whenever you try to lift the scrotal surface, the pain because of the epididymal-orchitis, that is relieved. But if there's a torsion of the testes and you try to lift the scrotum, then what happens is like the pain aggravates on lifting or the elevation. This is important clinical sign to differentiate the epididymal-orchitis from the torsion of the testes. Now, talking about the investigation for the epididymal-orchitis, again, you'll start from the baseline investigation. You'll send a blood CP, you'll look for the TLC count, and then obviously you'll send the ESR and the C-reactive protein as well to see if this is the kind of the infective or the inflammatory process or not. And then obviously you'll go for the urinary and urine routine examination and culture for the urine as well, because obviously you need to find out the focus for that particular infection. And obviously if you're screening the young group of the men, then obviously you have to screen the other partner as well to look for the sexually transmitted diseases. So if we particularly talk about the investigation of the epididymal-orchitis, you would go for the urine specimen for culture. Why this is important? Because you have to go for the targeted antibiotic therapy. So always, and the focus, obviously, I already discussed that the focus can be from the urinary tract infection. So for that, you'll go for the urine routine examination, and you'll send the specimen for the culture as well. Then there's another important thing, which is the NAT, and this is the nuclear amplification testing, and you go for the urine or the urethral swab as well. You send the urethral swab and you go for the urine swab as well for the nuclear amplification testing, and just to find out the organism, causative organism behind the epididymal-orchitis. And the most important investigation is a sqaudal ultrasound, if to see to differentiate it from the inguinal hernia, hydrocele, or the varicocele. Because if there's a hydrocele, I would say there would be fluid, and if there is most of the time there would be in case of the hydrocele there would be fluid, but in case of the inguinal hernia, obviously there would be kind of the omentum or the gut loops in that. And in case of the varicocele, there would be dilated channels as well. And in case of the epididymal-orchitis, obviously you can see the free fluid in the sqaudal region. And then urethral swab, this is something very important. Again, you'll send the urethral swab for culture to find out the causative organism. So if we particularly talk about the treatment of the epididymal-orchitis, we know that this is a kind of the inflammatory process. So the main focus would be to give the patient a good analgesia, to hydrate the patient, to give a good symptomatic relief to the patient, to give a good sqaudal support, and put the patient for the antibiotic therapy. So if we talk about the regimen for the antibiotic therapy, the drug of the choice would be doxycycline, which is 100 to 200 milligram twice daily, or you can put the patient on a quinolone group. They've got a very good effect in case of the epididymal-orchitis. And obviously, if the causative organism is a urinary tract infection, then you'll think about other causes. You'll think about giving a targeted therapy against that particular organism. So the treatment modality is basically, most of the time, it's a conservative treatment. You put the patient on the antibiotic, and most of the time the antibiotics are like the doxycycline or the quinolone group. Then you'll enforce the hydration of the patient and drink plenty of the fluids and plenty of water as well. Give a good analgesia, and sqaudal support is something very much important. So conservative treatment include antibiotics, good hydration, good analgesia, and obviously then the sqaudal support. And sometimes maybe if the acute episode of the epididymal-orchitis is not resolved, then obviously it would be developed into the chronic epididymal-orchitis. And we know that the chronic inflammatory process, it's like obviously when the acute infection has kind of the some kind of the focus of the inflammation left behind and it's not fully resolved, there would be fibrosis. And ultimately, we know that whenever the tissue is fibrosed, the liability of that tissue is very much compromised, and obviously there would be testicular atrophy, and there would be some kind of the fibrosis will lead to the testicular infarction and the atrophy, and ultimately it would be a cause of the infertility, especially if the epididymal-orchitis is bilateral. If it is unilateral, the other testes would compensate it, but if it is bilateral, obviously, and the chronic inflammatory process will lead to the fibrosis, and the extensive fibrosis will ultimately lead to the testicular atrophy, and ultimately leading to the process of the infertility. So again, in case of the chronic diseases or the chronic inflammatory process like the chronic epididymal-orchitis, you have to put the patient on the anti-inflammatory agents. But in case of the acute infection, you put the patient for a 2-week antibiotic therapy. But in case of the chronic inflammatory process, you have to put the patient for 4 to 6 weeks. Obviously, it will take a lot more time to resolve the old inflammation or to resolve the fibrosis. So you have to put the patient on the anti-inflammatory agents You have to combine it with not only the antibiotics, but also the anti-inflammatory effect, like the NSAIDs as well, because they have a good anti-inflammatory effect. So you prolong your treatment to 4 to 6 weeks instead of 2 weeks for the acute inflammatory as compared to the chronic. So again, in case of the chronic epididymal-orchitis, the choice of the antibiotics is like quinolones and the doxycycline. But obviously, if you have got the culture for the urethral swab, or you have got the reports of the urinary tract infection, then you have to treat that particular organism, and obviously the sensitivity of the antibiotic would be determined by the culture. And in case of the chronic diseases that have led to the testicular atrophy, and there is not so much of the viable tissue left, then you go for the epididymal or orchidectomy. Sometimes it can be epididymectomy, or if it's only involving the epididymis and the testes are viable. But if the viability of the testes is also compromised because of the testicular atrophy, and you're sure about the infertility, then you have to go for the epidydymectomy and orchidectomy, and you have to ensure the patient about the consequences, because when the tissue is not viable, then obviously the choice of the treatment would be epidydymectomy or the orchidectomy, and obviously these two procedures can lead to the infertility, so you have to counsel the patient for these things. So always keep in mind, for the chronic diseases, you have to give the antibiotics for a longer period of the time, for like 4 to 6 weeks, and obviously you have to combine them with the anti-inflammatory agents like the NSAIDs, and you have to give a good analgesia if the patient is complaining of the persistent testicular pain. And if the process of the fibrosis is extensive, then you have to go for the surgical options like the epidydymectomy or the orchidectomy, and you have to counsel the patient for the infertility. So always keep in mind anti-inflammatory agents, antibiotics, epidydymectomy or orchidectomy in case of the chronic diseases. And if we particularly talk about the process, or if we talk about the procedure for the orchidectomy, so it's simply like you're giving incision on the sqadia region, and you're going through the dartus pouch. You're opening the skin, subcutaneous fascia. You're opening the dartus pouch. You're holding the testicles like this, and you have to ligate the testicular cord and separate the testes from the epididymis. And if you're only doing the orchidectomy, then you have to separate the testes from the epididymis. And obviously, sometimes if you are performing the epididymal orchidectomy, then whole of the testes with the epididymis, they are removed. They're separated from the seminal vesicles, and then they are removed, and the dartus fascia is closed, and the skin incision is again closed. So you can see here in the diagram, these are the testicles. You can see here the spermatic cord. We know that actually these are the blood supply of the testes is the testicular artery, so this is important to ligate the testicular artery and to ligate the spermatic cord. And because the testicles are again connected through the epididymis, through the vas, so you have to ligate the spermatic cord. So you have to separate the testes along with the epididymis from the spermatic cord, and then you have to remove them and close the remaining incision. You can see that the cut in the groin, sometimes you can approach giving the cut in the groin, and you have to separate the testicles from the spermatic cord to this groin incision. And sometimes you need to give the incision in the subcotal skin as well, and separating the testicles from the dartus and mobilizing the testicles, and then removing that. This is the orchidectomy, which is very much simple and easy. There's another entity which is the tuberculous epididymal-orchitis, and let me tell you, this tuberculous epididymal-orchitis is a kind of the chronic inflammatory process. We know that in case of the tuberculous epididymal-orchitis, the causative organism is obviously Mycobacterium tuberculosis, and the targeted therapy should be against that. Like you have to put the patient on anti-tuberculous therapy. But sometimes it's not like that the patient will have isolated tuberculous epididymal-orchitis. The focus can be somewhere else. Like there can be a primary tuberculous epididymal-orchitis, there can be secondary epididymal-orchitis. So the primary is like the focus of the infection is only in the primary focus is in the epididymis or the testes, and in the secondary the focus can be somewhere else, like it can be abdominal tuberculosis, or it can be it can be pulmonary tuberculosis, and there can be a kind of the seeding of that Mycobacterium tuberculosis in the epididymal, in the epididymis and the testes as well. Always keep in mind that since it's a chronic inflammatory process, so you can see here in the diagram that there would be kind of extensive fibrosis, and you have to give the antibiotics as well, but you have to put the patient on the anti-tuberculous therapy as well. So the clinical features for the tuberculous epididymal-orchitis would be like, again, there would be swelling, but history will be kind of little bit prolonged as compared to the other acute bacterial epididymal-orchitis. And the patient will also give a history of the weight loss, which is also very much significant, right? And there would be swollen, craggy epididymis, and obviously because of the extensive process of the fibrosis, there would be beating of the vas as well. This is the typical characteristic finding you will find in the patient of the tuberculous epididymal-orchitis. And in most of the time, like there is a secondary hydrocele, and 30% of the cases who are presenting with the tuberculous epididymal-orchitis. So this is one of the clinical feature you have to keep in mind. And there would be evidence of tuberculosis somewhere else, like the pulmonary TB or the renal tuberculosis. But sometimes, since it's the urogenital tract, so most of the time the primary focus of the tuberculosis would be in the kidneys. So if you are talking about the tuberculous epididymal-orchitis, you have to keep in mind the clinical features, including the swollen craggy epididymis. There would be beating of the vas deferens, and it will always be accompanied in like 30% of the cases with a lack secondary hydrocele, and there would be kind of the evidence of the tuberculosis elsewhere, like the pulmonary TB, abdominal TB, or renal tuberculosis as well. In case of the investigation for the tuberculous epididymal-orchitis, again starting from the baseline investigation, you go for the urine and the semen analysis. You have to go for the chest radiograph as well, because if there's a pulmonary TB, the focus of the tuberculosis would be the apices of the chest. So always go for the chest radiographs, and also you go for the ultrasonography in case of the tuberculous epididymal-orchitis. And since you have to put the patient on the anti-tuberculous therapy as well, and then since it's a chronic process, it can lead to the testicular atrophy, it can lead to infarction, and then the choice of the treatment obviously would be epidydymectomy, combining it with the orchidectomy. So because it's in case of the tuberculous epididymal-orchitis, the chronic inflammatory process will obviously lead to the extensive fibrosis, causing the testicular atrophy, and obviously at the end there would be infertility, and because of that you have to go for the epidydymectomy or orchidectomy in case of the tuberculous epididymal-orchitis. So there's another entity which is the orchitis, and in case of orchitis, the isolated inflammation or the infection of the testes is the orchitis. So if it's combined with the epididymis, like involving the epididymis as well, so that would be epididymal-orchitis. But in case of the isolated inflammation of the testes or the isolated infection of the testes, that is orchitis. So what is important in case of the orchitis, that there can be a number of causes for the orchitis, but most commonly in the young, the teenager group and the young adults, the most common is a viral mumps. Actually, mumps, the presentation is like the development of the acute painful swelling of the parotid gland. It also involves the swelling of the testicles as well. So if a patient is presenting to you with a testicular swelling only, and you're suspecting orchitis, and you have to ask about the history of the parotid swelling as well, because very much important for the viral mumps. And the tuberculous organism can also lead to the isolated inflammation of the testes, which is tuberculous orchitis, and obviously you have to put the patient on anti-tuberculous therapy. Another important thing is, in case of the viral mumps, if you put the patient on on antibiotic therapy, that will only be prophylactic. Otherwise, mostly the viral mumps is dealt with the good hydration, good analgesia, plenty of the fluids, and a good sqadia support. In case of the orchitis, there's another entity which is called the syphilitic orchitis. And in case of the syphilitic orchitis, obviously the presentation would be the same, but there would be gumma formation, and you can, on histopathological evidence, you can see it. This is again the part of the the diagram of the genital tract. You can see the scrotum, and inside the scrotum there's inflamed testes, and rest of the epididymis and the vas is approximately normal. So in case of the orchitis, there would be isolated infection. So particularly talking about the orchitis, think about the viral infection, particularly the history of the mumps, the painful swollen parotid gland along with orchitis, and you will counsel the patient about the testicular atrophy. You'll counsel the patient about the causative consequence of the infertility, and you can think about the tuberculous orchitis, and you can also think about the syphilitic orchitis, and there would be formation of the gumma. So far in this lecture, we had discussed about mostly the inflammatory process and the epididymal cyst and the spermatocele. And in case of the smaller cyst, like if it's a spermatocele or the epididymal cyst, you can ignore them. But in case of the larger one, which are making the patient symptomatic, or the persistent dull ache testicular pain, and also causing the testicular atrophy, you have to go for the excision or the epididymectomy, depending upon the symptoms and depending upon the consequences of the cyst or the spermatocele. The other and the most common important thing we have discussed so far is epididymal-orchitis, and you have to differentiate it from the torsion of the testes, because in case of the torsion, there's extreme excruciating pain of the testes, which is usually disproportional. But in case of the epididymal-orchitis, you can differentiate it from the torsion on the basis of the history and on the basis of a clinical examination, like lifting up the testes. And then we have also discussed about the treatment modalities, like putting the patient on a conservative treatment, like putting the patient on good analgesia, good hydration, good sqadia support, and antibiotic therapy. And then we also discussed about the tuberculous epididymal-orchitis, the chronic processes, and in the end, the viral orchitis as well, and the syphilitic orchitis as well. So that's all for today's lecture. For other lectures regarding the general surgery course, keep watching sqadia.com. Thank you so much.